Well, as Ali said, I'm Dan Matlock. I'm actually a geriatrician at the university, and I lead the program in patient-centered decisions. We were originally developed as the shared decision-making core, and through some work with some local foundations, we found that some of them had very strange and narrow definitions of shared decision-making, and so we tried to broaden our name a little bit to encompass a little more of what we really want to do, which is really support patient-centered care. So we do a lot of methods, work, and support around patient-centered care, but we also do a lot of our own research. So next slide. Here's an example of a screenshot from the front page of our website. And I just show this to show sort of the breadth of some of the tools we've been involved with developing. I'll highlight a couple. The implantable defibrillator on the far left is one that I've been working on for 13 years or so. It was the subject of my K Award years ago. And we have gone from the development phase through some testing, and recently this was noted by Medicare as an example of a shared decision-making tool when they mandated shared decision-making for defibrillators, something they had only done 3 times. So our website's now getting a few thousand hits a week because of that mandate. Another one, which I'll go into, is the left ventricular assist device. I'm going to go through sort of our research portfolio and that just as an example of the type of research. I thought one of the better ways to show what we do in our core is just to give an example and also show we work a lot with the qualitative core and the D&I core. Those are probably the 2 cores we work with the most, in addition to the analytic and biostatistical cores. But I thought it'd be a nice way to tie together some of the stuff that Brooke and Russ just talked about as well. Next slide. So just a couple background slides on an example. These are 2 guys from one of the videos we made for left ventricular assist devices. They're almost identical on paper to white guys in their 60s who both have end-stage heart failure. And Cliff on the left chose to get this LVAD, this very life-prolonging but very aggressive procedure, and Don on the right chose not to. And they both agreed to be filmed for one of the videos we made as one of our decision aids. Next slide. And so this LVAD is, just very briefly, a couple slides. I didn't want to dig into the example, not knowing who was going to be on the call without a little bit of background, but this is basically the modern version of the artificial heart. On the left there is Barney Clark, who was the first artificial heart, lived for, I don't remember, 100+ days or so. But that's now evolved into this left ventricular assist device. And there's Vice President Cheney showing some of the stuff from his LVAD. And he had one for 2 or 2.5 years before he got his heart transplant. Next slide. So this is the front page of a decision aid we made. We worked with the qualitative core, and I worked with Larry Allen in heart failure and Colleen McElvin in the heart failure team. And we started with a lot of interviews of patients and clinicians and LVAD coordinators, nurses, and docs who do these procedures, and did a needs assessment and just asked them, what goes into your decision? What do you need people to know? What do you want to communicate? And that formed the background for the development of this tool. So here's the front page, and the next few slides, while presenting some of the background of the LVAD, also shows some of the images that we've made in our tools. Next slide. So this is what the LVAD is. It's a pump that sort of you punch a hole in the ventricle of the heart and suck blood out of it, and then pump that blood down the aorta, and you give yourself more output. It's very simple. You know, that's essentially what it does. The challenge is it's got this wire that's connected to the outside world. And you have to wear this battery pack and wear this controller. And so while it gives you more output, it comes with this burden that you have to carry of these batteries and this potential source of infection. Next slide. So this is the benefits of the LVAD. They're huge relative to about anything else we do in medicine. This is one of the early studies of LVADs, and people who didn't get an LVAD at 1 year, only about 25% were alive. And with the LVAD, about 75% were alive. And so this figure on the top left is a figure that we showed in our tool of what are the benefits of an LVAD. And you see these 10 faces, or these 10 little people. And this is an evidence-based way to communicate statistics to people in a way that they're more likely to remember than just saying, oh, a 50% increase or 80%. There's a lot of research that people don't necessarily understand those as well as presenting statistics with an icon array like this. So we use some of that science to better informed patients. And then there's also a quality of life improvement with LVADs for those who do well with it. Next slide. But this is a pretty graphic slide. I stole it from Larry Allen, so I'm going to blame him for the graphic display of blood here. But this comes with a lot of downsides, and you can just, I won't go through all these, but you see we use that same way of presenting information to people. I mean, there's a whole science around how do you communicate information to people in a way that they'll understand, and that's kind of some of the expertise that people in our core have. Next slide. So we made this tool and we studied it, funded by PCORI. We've been funded by the NIH and PCORI around this, and we wanted to understand both effectiveness and implementation. And we studied this in 6 sites around the country. Next slide. We use the RE-AIM framework, and Russ is humble enough to not put his name on this, but he's the name nationally that's linked to this framework. He developed it. We're really lucky to have him here leading our D&I core. He would very quickly want to acknowledge all the collaborators that he worked with on this, but if you go around the country, people know it as Russ Glasgow's RE-AIM framework. This is the most common framework used in implementation grants at the NIH, last I heard. And it's nice. And what I like about it, and what Russ kind of talked about, is so much of medical research, especially when I talk to cardiologists, we just focus on effectiveness. But there are so many other outcomes that are important. Yes, do we want our decision aid to be effective? Of course, but we also want it to reach patients. So we need it to fit in the workflow. We also want sites to adopt it. So we need clinicians to agree with what's in there. And we also need it to be easy to use. And we also want it to be used once the grant's done. We don't want it just to be something that's people use while doing the grant. So this is how we took our development work on the shared decision making, worked with the D&I core. Russ taught me a lot about this framework and many others to try and apply this science. Next slide. And so when we studied this, we would look at things like, did people feel it was balanced, or did they feel it was biased? And most of the patients felt it was pretty well balanced, or it was biased in favor of the LVAD, which is good in a way, in that most of the docs were scared that our tools were biasing patients against the LVAD. And that middle bullet there, that's the reach. In our trials, 88% of people got the pamphlet and 92% got the video. So that's that reach outcome of the RE-AIM framework. Just other important outcomes aside from effectiveness, if you really want to have your intervention or whatever you're working on have an impact. Next slide. And then some of the outcomes that we talk about in our core are patients improving their decision quality, or is the care more patient-centered? This is a buzzword right now. There's a lot of people wanting to do more patient-centered care, but what does that mean? And I've heard it all the way from, oh, it improved quality of life, that's patient-centered, or something else. Well, the definition that we use is the patient better informed, and are they getting things consistent with their values? So if you look at this slide, we saw a small improvement in knowledge. And if you go to the next slide, but a pretty big improvement in value treatment concordance when people saw our decision tool. So this was exciting to us. And our current project that we're just finishing now, following up on this, is doing a national dissemination of this tool. And there's 175 programs in the country that are accredited to do LVADs. And we have 123 of them using our tool, with about 100 of them using it as standard of care. And Russ obviously was instrumental in helping us design our national dissemination plan. And then we've worked with the qualitative core, Carolyn Teitbolt, one of Brooke's colleagues in the qualitative core, who is helping us evaluate. And we're going around interviewing the programs. We're interviewing some who've adopted and some who haven't adopted, trying to figure out why. What could we do to tweak our program to make it more adoptable? Or are the barriers to adoption just some local thing that we're not going to be able to surmount? But that's a way we're working with both of the cores that were just presented to try and understand, how do we take this intervention that we know is effective now and get it out to more people? Next slide. We can skip this slide. So again, just reiterating, our program, we have some expertise in the methods of shared decision-making and patient-centered care and patient-centered measurement, but we also have to lean heavily on a lot of the other cores at accords in order to do the work we really want to do. which is get something out in patients' hands that is usable and effective, and that the healthcare system can adopt. So this is partly why I have found Accords to be a great home for me and my research, just because it's a great community. And then I'll be in trouble because when I talked to Allie on Monday, I was supposed to add a slide of how you consult with me, just like Russ and Brooke did, and I totally forgot. So if you would like to consult with me, please just go ahead and reach out. On the earlier slide where I showed the clip from our website, there was a QR code that has a link to our page as well. And sorry, Allie, that I forgot to do that.
Also, a thank you from me, Allie. That was great. Thanks to all.
Thank you very much for having us.
Thanks.
Greatly appreciated.